I had some problem with my presentation. Uh, I just need 2 or 3 minutes if you can give me, okay?
That's all right, sir.
Hello. Hello. I cannot listen.
Hello. Yes,
Yes.
Dr. Sheila, patience, patience.
Dr. Amr is having some problem with his connectivity, so he's asked everyone to wait for a few minutes.
Yeah. Just one more minute, I'm sorry.
Yeah, sure.
Just No?
Yes, sir.
Yeah. So can you see the screen?
Yes, yes, we can see it.
Great. So it's a very short
Yes.
mock exam. I will just go through the most common cases of strabismus that usually come in FRCS exam part 3. So I want volunteers. So who will take the first question?
Okay, doctor, I'll take.
Okay, Dr. Arshi.
Yeah.
Describe, please.
Okay. So, if I see the person in the center of the picture, when he's looking in the primary gaze, the left eye is looks a little bit smaller, and I mean the ptosis, and it is outward deviated. And when he looks upward, the right eye is moving up in the elevation, but the left eye is not getting elevated. And
Okay.
when he is looking towards the right gaze, the right eye is abducting, but the left eye is not adducting. But in the left gaze, the right eye is abducting, and the left eye is abducting, but the right eye in the adduction position, it is going upward. So upward elevation during the adduction. And
Okay.
when I see the in the center, when he's looking down, then again the left eye is not getting depressed. The right eye is going okay. And when he sees towards the right side, I mean, levo will say dextro depression, then the left eye is not adducting, and is not levo, it's not going towards the nose side, but the right eye is moving. And in the opposite, um, in the levo depression, I think both the eyes are moving. So if I see this one, I'll say that this looks like the
Yes.
third nerve partial third nerve adduction is restricted, and there's mild ptosis of the left eye, so I'll say partial third nerve is
Okay.
gone.
So
Third nerve
this is
palsy.
partial third nerve palsy. Is there anything
Yeah.
to add?
Um. mm, right now I can see only this thing,
Okay.
and
So
there is
regarding
narrow. Yeah, that's all.
so
That's all.
regarding third
I
nerve
cannot see
palsy,
the pupil size. Yes, yes, their pupil is also dilated. The pupil
so
is dilated. The left eye pupil is dilated, so it is like pupil involving third nerve palsy.
exactly, great. So whenever you are um, describing a patient with third nerve palsy, you need to say whether it is complete third nerve palsy or incomplete third nerve palsy, and whether pupil is involved or not involved. So you need to comment on both things. So incomplete third nerve palsy, usually we have complete ptosis with limitation of adduction -4, limitation of elevation and depression -4. In incomplete palsy, like this case, in adduction, patient is having limitation of adduction maybe -1 to -2, limitation of elevation around -3, and limitation of depression -2. Okay,
Yeah,
and patient is having partial ptosis as well, but the
yeah,
pupil is involved. So
yeah,
patient can have incomplete third nerve palsy with pupil involved, or he can have complete third nerve palsy with no pupillary involvement. So they are two different things.
yeah,
Okay.
yeah,
So you did a great job, but I would recommend when you start
yeah,
describing, you will say this is a 9-gaze photo, a 9-gaze external photo of a 9-gaze patient, and then you will start as you mentioned.
okay.
Okay, so regarding this patient, he is a 20-year-old male. So what do you
Yes.
think the cause of such condition?
So as it is a pupil involving, so I would think of some surgical, I mean some tumor or aneurysm, which is compressing the optic nerve and compressing the pupillomotor fibers.
Okay, so
So they can
you
be
mentioned
at
two
any
causes,
level.
tumor, aneurysm. What else?
Um, there can be cavernous sinus issues, or there can be tumor, there can be trauma, tumor,
Yes.
infection, yeah, vasculitis.
Mhm.
So from starting from the superior colliculus till the it can be intracranial, it can be intracavernous, it can be intraorbital. So
Great.
at any
So
position it can be there.
great. So this patient actually had a history of falling down 2 years ago,
Okay.
and
Yeah.
after falling down, he had this condition. Okay. So how would you manage this patient?
So the management will depend on his complaints, like if he's having diplopia, or if his vision is reduced, depending on that. So we will start from the visual acuity. After the visual acuity, we will do the extraocular movements and the squint estimation that we did. After we will see the diplopia, double vision, in which if there is any head or face head tilt is there, or the face turn is there, and it is causing any problem to the patient, like
Mm,
cosmetic diplopia or anything like that, then in the retina we have to see if there's optic nerve atrophy, anything is there,
mhm,
or any maculopathy, macular scarring is there. Um, then pupillary reaction is very important. We have to check for the consensual as well as the direct pupillary reaction, uh,
mhm,
which will let us know if the optic nerve conduction is fine or not in this eye because of the
okay.
trauma. Um, then Mm, then accordingly we have to do, of course we have to do CT scan. In that we can do CT angiography or MRI, depending on whatever
So,
is
so, so
available
re-
in the place.
regarding anomalous head position you mentioned, what do you
Yes.
expect in such patient? What type of anomalous head posture he will have?
um since um since he is not able mm, to look towards the right side properly, so
Mm,
I think that he will be having his face turned towards the right side. And adduction, because the elevation and depression both are
yes.
equally
Yes. So, so,
restricted,
so,
so I don't think so there'll be
yes.
any
So
chin
usually
position needed.
with third nerve palsy will have face turn toward the opposite side.
Yes,
Yes.
so it will be
Okay.
towards the right side. Yeah.
So this patient is having vision 6/6 and he's complaining of diplopia. How will you
Okay.
manage the patient?
Okay. So the management will depend upon the history also, like if the trauma and the diplopia is 6 months over, or is it within
It
the
is
six
already two
months?
years, as I mentioned before. Two
Already
years.
2 years. Yeah.
Yes.
Okay. So then we don't think that it's going to the nerve will is going to come back. So in that there are various techniques depending on the conservative management and
Yes. Dr. Arshi,
interventional surgical management.
whenever you are asked in the exam, you will be asked about the specific patient. I am giving uh, the picture,
Okay.
of the patient. So just
Yeah.
try to be focused because in the exam you don't have so much time. So
Okay.
try to have more
Okay. So
focused answer.
either we can do occlusion technique to
Okay.
avoid the diplopia. That will be a temporary measure. We can do Botox injection in the lateral rectus to make a paresis of lateral rectus also, so that the eye come in the center. Or we
Mm.
can go for the surgery. In the surgery, we can do the lateral rectus recession.
Okay. So in such patient, you will do lateral rectus recession. Anything else can be done?
Yeah, we can also do splitting of lateral rectus and attach it with the superior inferior. That is called transposition. Mm, so that with the superior and inferior rectus muscle, if we make a two muscle we divided into superior and inferior and attach with the superior rectus and the inferior rectus. One half will be attached to the inferior rectus, one half will attach with the superior rectus. And we can also do medial rectus resection.
Okay, so regarding the transposition, it is more common to be done in sixth nerve palsy, because in sixth nerve you have only the problem in lateral rectus, so we can do a partial vertical rectus tendon transposition. We can take half of the superior rectus and half of the inferior rectus and put it, transpose it temporally, just superior and inferior to the lateral rectus. But in third nerve palsy, usually we don't do that because already superior rectus and inferior rectus both are affected. So transposition would help you a lot. So yeah, in such
We can do
patient,
inferior oblique. Yeah. Okay.
in such inferior oblique also is affected because the patient is having third nerve, and third nerve
Yeah.
also will
Yeah.
supply inferior oblique. So in such
Yeah.
patient, you need to know whether the patient is having incomplete third nerve palsy or complete third nerve palsy. So if the patient is having incomplete third nerve palsy like this patient, and the patient is still having residual medial rectus action, so we can do medial rectus resection and lateral rectus recession, but usually we do larger number than usual because medial rectus is weaker than usual. So you need to do larger
More
resection.
resection.
Yes. In patient
But we
with,
cannot do more than 6.5 mm, right?
yes, up to 8 millimeters you can do. Okay.
Up to 8 millimeters. Okay.
Yes. In patient with complete third nerve palsy, where there is no any action of the medial rectus is dead, then usually we do very large lateral rectus recession, or another procedure that is called lateral rectus periosteal fixation, where we completely remove the action of the lateral rectus. So we fixate the lateral rectus to the lateral wall periosteum, and then we close the tenon so the lateral rectus will not attach to the sclera again. So we will do like removal of the whole lateral rectus action. Other options that can be done, one surgical procedure called nasal transposition of the lateral rectus, where we split the lateral rectus to two halves, and we transpose it, transpose the superior part beneath the superior rectus and superior oblique, and transpose it superior to the medial rectus insertion, and the lower half we will transpose it beneath the inferior oblique and inferior rectus, and we will transpose it to the inferior border of the medial rectus, and that again will like it will remove the action of the lateral rectus.
Okay.
So those are two
What is that?
options
What is that procedure called, which you told about, that you remove it from the periosteum? What is that procedure called?
lateral rectus periosteal fixation, LR periosteal fixation. The other one is called LR to MR, or lateral rectus nasal transposition. Okay. Those are two procedures that can be used for complete third nerve palsy. Okay. Thank you so much, Dr. Arshi.
Thank you.
We will shift to the next question. Who will take it?
I can take it, sir.
Okay, Dr. Zakaria. Describe, please.
This is an external photo of a patient in which the primary position, the left eye is in deviation. In dextroversion, there is not any limitation of the extraocular muscle movements, but in levoversion, the left eye is not abductant. So there is a left eye's abduction deficit in the left eye, which is consistent with left sixth cranial nerve pulse, sir. Other differential diagnosis would be, yes, sir.
Yes, Yes. So if I ask you, what do you think? This patient is having complete or incomplete sixth nerve palsy?
It is a complete sixth cranial nerve palsy, sir.
Okay. Why?
Because the abduction is severely limited.
Yes, the eye is
There
not
is not
even
any
reaching the
abduction in
midline.
the side.
Yes, the eye is not even reaching the midline.
Yes,
So
it's
the patient is having,
-4.
yes, it is even more than -4. That is
Yes,
called -5 limitation of abduction. -4 when the eye will reach the midline. But you can see here the just one second. You can see here the light reflex is
yes, the
still
Hirschberg.
temporal to the pupil.
Yes,
So the eye is not even reaching to the midline. So this is even more than -4 limitation of abduction. We call it -5 limitation of abduction. So that is one thing to differentiate between complete and incomplete sixth nerve palsy. In incomplete sixth nerve palsy, usually the eye will move more than the midline, like the patient
midline.
will have -1, -2, or -3 limitation of abduction.
Okay.
Other things to differentiate between complete and incomplete sixth nerve palsy, what can we do?
What can we do?
Other test that can be
To
done to
uh,
differentiate.
can we check the duction, sir?
Yes, ductions you will check. That is the same as this. Yeah, this we are looking for versions.
Okay.
When we are looking for ductions, we will confirm the limitation. Perfect. But what are other tests that can be done?
I don't have an idea, sir, about.
Okay, there is something called saccadic
Yes,
to
saccadic eye
notice
movements.
the saccades. So if you are having slow floating saccades and the eye is not moving past the midline, that is again denoting that the patient is having complete sixth nerve palsy. The second thing is a test called force generation test.
Mhm.
So force generation test is a test usually we do it under topical anesthesia and the patient is aware. And you will ask the patient to look at, for this patient will be looking at the right side. And then you will ask the patient to look at the left side. And you will check if there is any LR activity, if there is any tug of the lateral rectus muscle, if there is any remaining or residual action of the lateral rectus. So to differentiate between complete and incomplete palsy, first thing, whether the eye is moving past the midline or not. Second thing, force generation test. Third thing, saccadic velocity. Okay. So what do you think the cause of sixth nerve palsy in such patient?
So regarding the age of the patient,
Yes, he's around
some
60-year-old.
yes, some microvascular diseases like hypertension, diabetes mellitus,
Okay.
stroke, hemorrhage, and ischemia are the most common causes. Another
Okay.
cause is trauma, sir, of course, and also intracranial tumors are the
Okay.
causes.
Okay. If I told you the patient is 20-year-old, healthy male, so what are other causes that can cause sixth nerve palsy in such a patient in this age group, young age group?
Yes, trauma is, sir, the most common cause in young
And
ages, and also some intracranial infections like meningitis can cause the cranial nerve pulses,
what else?
and it could be congenital also.
Okay, congenital sixth nerve will be present since birth, yes, but
Yes,
regarding a young patient, always also you may consider multiple sclerosis as one of the most common causes of sixth nerve palsy.
yes, you're right, sir.
Okay,
Okay.
multiple sclerosis.
Yes.
Okay, so regarding this patient, how would you manage, Dr. Zakaria?
Sir, first of all, I would do a comprehensive ophthalmologic examination, checking visual
Okay,
acuity,
okay,
then intraocular pressure, pupil examination, extraocular motility. I would check the fundus because of the false localizing sign for increased intracranial pressure if there is
yeah,
any pupil edema. Then I would proceed with a neuroimaging, which includes for urgency computed tomography, for accuracy MRI.
Okay. And then?
And then if there is any intracranial pathology, so the underlying cause should be treated firstly. And then I would proceed regarding the cause of the palsy.
Okay, so let's say this patient experienced head trauma
Okay.
6 months ago, and after the trauma, he had this sixth nerve palsy. And the neuroimaging is normal. There is no abnormalities, no tumors, no aneurysm, no strokes, nothing.
Yes, sir. For these patients in acute phase, we should treat the ocular manifestations with prisms, Botox, and also patching. But for this patient, because it's happened before 6 months, so I would counsel the patient about the surgery, correcting of the surgical treatment for this patient. If he is okay with the surgery, I would continue with surgical treatment of the deviation, sir.
Great. What type of surgery?
Sorry?
What type of surgery?
Sir, I would do lateral rectus resection and medial rectus resection.
Okay, in such patient with complete sixth nerve palsy, do you
Yes,
think
sir.
that
I'm sorry, sir. Yes, I'm sorry, sir. If it is incomplete, I would continue with lateral rectus resection, medial rectus resection. If it's complete, then a vertical muscle transposition should be done for these patients, which means the superior rectus and inferior rectus transposition to lateral rectus.
Okay, so if it is incomplete, you will go for medial rectus recession and
Yes.
lateral rectus resection. If it is complete,
Complete.
you can again go with medial rectus recession and vertical recti transposition.
Transposition. Okay.
Yes, whether Hamilshine procedure or Jensen procedure or something called modified Nishida procedure. Okay,
Okay.
great.
Okay. Thank you.
Great. So, for each 1 millimeter of medial rectus recession, how much correction will happen?
About 3 to 4 prisma diopters, sir. Yes.
Yes, for 1 millimeter recession, we are expecting around 3 millimeter,
Yes, 3 to
prism
4.
diopter. Yes,
Okay.
yes, great, great. Okay, you mentioned also Botox. Botox can be used at which time? Like, what is the timing for Botox?
Sir, before surgery, for example, until the 6 months to decrease the patient's diplopia. So diplopia, we can inject Botox to the lateral, to the medial rectus.
Yes, you will inject Botox
Another
to the
options
medial
are patching or prisma.
Yes. Prism glasses, patching,
Yes.
or
And Botox.
Botox. Botulinum toxin usually will work in non-restricted muscle, and usually in a patient with sixth nerve palsy, if you wait for more than 1 month, medial rectus contracture will start to happen. So botulinum toxin ideally would be given within the first month of sixth nerve palsy. After 1 month, usually medial rectus contracture and fibrosis will start to happen, and botulinum toxin will not be effective. Okay.
Okay, sir.
Okay. So
Thank you.
another scenario of the same patient, if the patient does not have any history of trauma and fundus examination is normal and he is diabetic, how would you approach the patient?
And the patient is
Diabetic.
diabetic, does not have fundus examination.
Fundus
So
is normal.
because for this patient, as you mentioned before, it happened before 6 months. So
Yeah, I'm asking about another scenario.
most of them
Another scenario.
do not need any surgical intervention. So the regulation of underlying systemic disease most of the time is enough for these patients.
So yeah, so that is the point. If you have a patient who is 50-year-old or more, and he's having systemic diseases like diabetes mellitus, hypertension,
Hypertension.
hyperlipidemia, and fundus examination is normal, and he's having mononeuropathy, only isolated sixth nerve palsy, you can start with doing only systemic lab, like
Yes.
hemoglobin A1C, fasting blood sugar, fasting lipid profile, measuring the blood pressure, and you do
Yes.
not need to do neuroimaging. Okay?
Yes, yes, you are right. Yes.
Okay, great. Thank you
Thank
so
you.
much, Dr. Zakaria. Let's check
Sir,
with it.
doctor, in this, I can see there's some proptosis also of the left eye, or is it just appearing
No, just
proptosis of the left eye?
the patient is only staring, and he's having also a bit of
Papal
dermatochlesis.
fissure is,
Yeah,
yeah,
but
like there's a
it,
sterile show, or like,
yes, it's just like staring, but yeah, no other
yeah.
problem.
So
Okay.
should he be investigated for thyroid also?
Yes, if there is a prominent, or you are suspecting any thyroid problems, you can also go for thyroid function test as well. Yes, you're right.
Okay,
Great.
thank you.
So who will take the third question?
Yes, sir,
Anyone?
I'll take it.
Okay, Dr. Hiba?
Yes.
Okay, describe please.
So in primary position, I can see right eye esotropia, right eye deviating inward, and
Okay,
then dextroversion, there is no deviation, either in the superior dextroversion or inferior, and also levoversion, no deviation, either in superior or inferior.
okay.
And in up and down, I can see V pattern.
Actually, yeah, there is no significant V pattern, but yeah,
Okay.
maybe small V pattern, yes.
Mhm.
Okay. So what's your diagnosis?
So my diagnosis, as the age, it seems to be a young age. It's maybe accommodative esotropia.
Okay, so first of all, this is a case of comitant esotropia. Am I right?
Okay.
So
Okay.
you need
Comitant.
first, when you are classifying patient with esotropia, whether it is comitant or incomitant. So how to
Yeah.
differentiate between both? Comitant esotropia means that the
Means same
patient,
angle.
yes, same angle
Same angle.
in all gazes and full
Yes.
extraocular motility. Am I right?
Yes, same angle in all gazes and full extraocular motility.
Yes, and primary deviation equals secondary deviation. So whether you put the prism over the right eye or the left eye, you will have the same angle of deviation. There is no difference.
Mm-hmm.
But in incomitant esotropia, what we are having, that the patient will have limitation of extraocular motility. That is one sign. The second sign is when you are measuring the angle of deviation in primary position, right gaze and left gaze, you will find differences. And the third sign is when you are putting the prism over the deviated eye, you will get something called the primary deviation. And when you are putting the prism over the non-deviated eye, you will get something called secondary deviation. And usually secondary deviation more than the primary deviation.
Deviation.
Okay.
Mm-hmm.
So
Okay.
regarding comitant esotropia, what are the differential diagnoses of a patient with comitant esotropia? What are the causes?
Essential esotropia, or
Yes.
accommodative, or
Yes.
partially accommodative, or
Yes.
convergence excess.
Yes, or high AC by A ratio esotropia. Great.
Mhm.
And what about one more thing? Acute acquired comitant esotropia, AACE. That is one entity of esotropia that is happening in acute manner, but it is also comitant. So it's called acute acquired comitant esotropia, AACE. Okay, great.
Right.
So what is the differential diagnosis of incomitant esotropia?
In concomitant esotropia, so it is either paralytic or restrictive.
Okay,
So in this age group, maybe sixth nerve palsy.
okay. And
Duane syndrome.
Duane retraction syndrome type 1, which will present usually with esotropia. Great. So coming back to this case, this is a 5-year-old child who is having esotropia since 3 years. How would you approach the patient?
Okay, I'll take a good history from the mother about the prenatal and postnatal history, and then I'll take a good history about the esotropia, onset of esotropia, and if it is intermittent or continuous, and I'll check for vision and complete my ophthalmological examination anterior segment and posterior segment. Then I'll go for cover and cover test and extraocular motility.
Okay. What else? One more thing you need to do.
I'll do refraction.
Yes, what type of
cycloplegic refraction.
Yes, exactly. You need to mention this. You need to do a cycloplegic refraction to get to know what is the amount of hypermetropia, if any, in this patient. What is the total amount of hypermetropia? Okay, great. So let's say that this patient is having +5 hypermetropia in both eyes. What will you do?
I'll give the full correction to the patient, and I'll follow up again after 1 month, and I'll measure the angle for distance and near. If there is a residual angle, if the patient is fully corrected on glasses for near and far, so it's okay. If it is corrected for if there is a residual angle, I'll go for surgery. If there is no angle for distance and there is a residual angle for near, I'll go for bifocal glasses.
Okay, what is the name of the third type of esotropia?
The third type?
Yes, the one that you mentioned at the end, if the patient is still having residual angle at near,
yes,
but he's at distance.
ACA, convergence insufficiency.
No,
convergence excess. Convergence excess.
High AC by A ratio esotropia or convergence excess esotropia. Great. One more thing you didn't mention is that you will check the visual acuity with glasses in both eyes.
Yes, if there is amblyopia, I'll treat amblyopia first.
Yes. So in any patient with esotropia or any patient with strabismus, you need to remember always, you need to give the refractive correction. One. Secondly, treat amblyopia if any. Thirdly, do surgery if the patient needs surgery. Okay. So let's say after giving the full cycloplegic refraction for this patient, the patient is having residual esotropia of 25 prism diopter at near and 20 prism diopter at distance. What will you do?
So this patient need bilateral medial rectus recession.
Okay, so how much would you do for such patient?
I don't know.
Okay, maybe around 4 millimeter bilateral medial rectus recession. That will be enough. Okay, one more thing I would suggest, because usually before taking the patient to operation theater, we need to repeat cycloplegic refraction at least twice. At least twice, because maybe in the first time the patient was not fully cyclopleged, and the ciliary muscle are not fully relaxed. So it's preferable to repeat the cycloplegic refraction at least twice before saying that the patient is having partially accommodative esotropia and he will need surgery. Secondly, as I mentioned before, if the patient is having any amblyopia, we need to treat amblyopia before taking the patient to surgery. Okay, so we need to make sure that the patient is having equal vision in both eyes before going to surgery. Great. So last question, if the patient is having equal vision in both eyes, what type of surgery would you recommend?
Bilateral medial rectus recession.
And if the patient is having one
unicular, I'll do surgery on the amblyopic eye, but I'll do medial rectus recession and lateral rectus resection.
Yes, after maximally treating the amblyopia, then if you are going to do the surgery, you will do it preferably on the amblyopic eye. Great. Thank you so much, Dr. Hiba.
Thank you. Thank you.
Sir,
Move.
sir, I had a question.
Yes.
Sir, how did you calculate that around 4 mm correction in each eye to treat the 20 prism diopter esotropia?
Okay, so usually what we are doing is using nomograms. We don't just calculate the amount of deviation, and and because it is not a linear relationship. For example, I am doing 2 millimeter medial rectus recession. For example, it will correct unilateral 2 millimeter medial rectus recession. For example, it will correct 6 prism diopter.
Right,
That
right.
does not mean that 4 millimeter will correct 12. It might correct more.
Okay.
Okay. So
Okay.
what I'm trying to say, we usually use nomograms, but sometimes in FRCS exam, you might be asked for each 1 millimeter of medial rectus recession, for example, roughly how much it will correct. Okay.
Right.
So roughly medial rectus recession 1 millimeter would correct around 3 prism diopter.
Yes.
And for lateral rectus, usually it is less. It is around 2 prism diopter. Each 1 millimeter lateral rectus recession would correct around 2 prism diopter. But as I mentioned, it is not a linear relationship, and we usually, I am as a strabismologist, I am using nomograms. Okay.
Okay, sir. Okay. Thank you.
But sometimes you might be asked such questions, so you just need to say, I usually use nomograms. There are many nomograms for strabismus surgery in different strabismus books, so I usually use nomograms, but roughly for each 1 millimeter of medial rectus recession or resection, it would correct around 3 prism diopter, and for each 1 millimeter of lateral rectus recession or resection, it would correct around 2 prism diopter. Okay.
Okay, sir.
Okay. So who,
For all the squint corrections, I mean, when we are estimating, we have to do prism bar cover test for distance as well as for near. In
yes,
every case, we have to do like that.
exactly. Yes. So if you are having any strabismus case, you need to say, I would like to do alternate prism cover test at near
Yeah.
and at distance. Also
Okay.
in different side gazes, right gaze, left gaze, up gaze, down gaze, and also right head tilt and left head tilt if there is any vertical deviation present. Okay.
Okay.
And also, I want to do alternate prism cover test with and without correction to determine if there is any accommodative component, especially in
Okay.
patient with esotropia. Okay.
Yeah, but it will take so much time if
Yes, yes,
maybe
but
I'll.
you need to say that so the examiner
Okay.
will understand that you know what should you know how to work up a patient with strabismus. But usually
Yeah.
what the examiner will let you do in the exam is doing the alternate prism cover test at near and at distance. They usually need that only. But theoretically, you need to say everything because in strabismus clinics, we do everything. Why we do everything? For example, in any patient with horizontal deviation, I need to do the measurement in up gaze and down gaze to determine if there is any pattern strabismus, if there is any
Yeah.
B pattern or A pattern. Also, I need
Yeah.
to do the side gaze measurement, right gaze and left gaze, to determine if there is any lateral incompetence. Okay. And
Okay.
we do the third step, the measurement in right head tilt and left head tilt to complete the 3-step test if the patient is having vertical deviation to get to know which cyclovertical muscle is affected. Okay,
Yeah. Okay. Okay.
great. Okay.
Thank you.
Okay, let's take the next question. Who will take it? Any volunteer?
Sir, I have a question, sir. Sorry.
Yes, yes.
If the angle of deviation is different for far and for near, And the examiner asked how much surgery would you do? How can we answer this question?
Which type of strabismus?
Esotropia. Let's say for this patient.
Okay, so in esotropia, if the difference is within 10 prism diopter, we call it basic esotropia. For example, if the patient is having esotropia at near 35 prism diopter, at distance 30 prism diopter, so this is basic exotropia. The difference is within 10 prism diopter. In esotropia, we usually go for the smaller angle. Okay. But if the patient is having the difference between near and distance deviation more than 10 prism diopter, if the distance deviation is more, so this is called divergence insufficiency type of esotropia. Or in patient with 6 nerve palsy also, they will have distance deviation. Distance esotropia is more than near esotropia. And the other scenario, if the deviation at near is more than distance, so this is called high AC by A ratio or convergence excess. And in such patients, we have two options: whether to do the mean of the two deviations, the distance and near, and we will take the mean, or we will take the distance deviation and we will correct it with medial rectus recession, and we will do something called Faden procedure or posterior fixation suture to treat the difference, to treat high AC by A ratio.
Do we do Faden for children's patients for pediatrics?
Yes, we do it for children. Yeah, there is no contraindication to do it. So I will give you an example: a patient with esotropia at distance 20 prism diopter, at near 40 prism diopter. So the patient is having high AC by A ratio esotropia.
Yes.
So in such patient, whether I will take 40 plus 20 divided by 2, so that is 30 prism diopter, so I can have my target angle as 30 prism diopter. That is one option. The second option is to aim for the 20 prism diopter esotropia. So for example, I will do maybe 3.5 millimeter of medial rectus recession in both eyes for the distance deviation, and I will add posterior fixation suture. The other name is Faden procedure to treat the difference, the high AC by A ratio. Okay?
Okay.
Faden procedure is for superior rectus or for any of the muscle we can do
for medial rectus in patient with high AC by A ratio. It can be done in superior rectus in patient with dissociated vertical deviation. So you can use it in different muscles for different indications.
Okay.
So if there is like, 20, 25 prism diopter, so do we have to split it between, if we are doing the medial rectus recession, so do we have to split it between the two eyes, then we calculate it?
Yes. Usually anything beyond 15 prism diopter, you need to do two muscle.
Okay.
Up to 15 prism diopter, you can correct it with one muscle, one medial rectus. More than 15, usually we do two medial rectus, bilateral medial rectus recession, but smaller numbers. Okay. So Dr. Asma, would you like to take the next question?
Okay, sir.
Okay. Describe, please.
So this is a external photograph of a boy with 9 gazes. In the central and the primary gaze, the left, it seems to be left deviation of eye, inward left esotropia, but there is a broad nasal bridge also. In the right gaze, the dextro version, it's okay. Levo version, in the levo version, the right eye seems to be uh, uh, deviated upward more, and in the down gazes, in the primary position, it seems to be okay. However, in the dextro deviation, dextro depression seems to be okay. In dextro elevation, in the levo depression also seems to be okay. Now comes the levo elevation. The right eye seems to be hyperdeviated, and whereas the left eye seems to be normal, and in the dextro elevation both eyes seems to be normal. So overall, while examining all the extraocular movement in all the gazes, it seems that there is overaction of inferior oblique muscle of the right eye.
Okay, great. So this patient is having left esotropia in primary position, as you mentioned, and the patient is having right inferior oblique overaction, maybe +3 inferior oblique overaction in the right eye.
Yes.
The left eye also, there is mild inferior oblique overaction, maybe +1 inferior oblique overaction in the left eye. Okay. So
Okay.
the patient is having asymmetrical inferior oblique overaction more in the right eye. And also here, there is mild superior oblique underaction in the right eye. Okay.
Fine. Okay.
So in such patient, my question is about inferior oblique overaction. How would you address inferior oblique overaction surgically?
So inferior oblique overaction by weakening procedure of the inferior oblique, or by strengthening the superior oblique muscle of the same eye.
Okay, when you will do superior oblique strengthening, when you will do inferior oblique weakening?
Isn't it the choice of surgeon to, because I think it's easy to operate on the superior oblique muscles when because the inferior oblique insertion is very close to the macula, so it's easier for the surgeon to operate on the superior oblique. So I'm not sure on what basis we prefer superior oblique or inferior oblique.
Okay. So regarding patient with congenital superior oblique palsy, congenital superior oblique palsy, where the patient will have superior oblique underaction and secondary inferior oblique overaction. If the patient is having a lax superior oblique tendon, like there is no like the superior oblique is very lax, there is no any tautness of the muscle. Sometimes we do superior oblique tucking, okay?
Fine.
But the more common procedure is inferior oblique weakening. It is much easier, and also the duration of the procedure is shorter. So we usually go for inferior oblique weakening procedure more commonly.
Fine.
Also,
Okay.
inferior oblique weakening can be done whether the patient is having congenital superior oblique palsy or acquired superior oblique palsy. Okay, and also in such patient, sometimes the patient will have something called primary inferior oblique overaction, where the patient will have inferior oblique overaction with no superior oblique underaction. Sometimes the patient will have something called primary inferior oblique overaction, and it is very common in a patient with infantile esotropia, in a patient with exotropia. So in such patient, we will do inferior oblique weakening. So what are the types of inferior oblique weakening procedures?
So it can be like disinsertion of inferior oblique, because it is marked inferior oblique weakening.
Yes, we usually do something called inferior oblique myectomy, or inferior oblique recession. So those two procedures are used for a patient with inferior oblique overaction. Okay, so inferior oblique overaction will cause which type of pattern?
So it's a V pattern with inferior oblique
Yes.
overaction.
with patient with inferior oblique overaction, patient will have V pattern, whether esotropia or exotropia. And in
Yeah.
a patient with superior oblique overaction, which pattern?
That is A pattern in the superior oblique.
Great, great. So in a patient with V pattern, for example, V pattern esotropia,
Yes.
what is the difference that we said that that is a significant V pattern? The difference between up gaze and down gaze measurement, how much it should be, at least?
It should be at least at the inferior oblique 15 up till 15 prism diopter.
Yes, in V pattern, usually the difference should be at least 15 prism diopter to say this is a significant V pattern. And in A pattern,
It is a 10 prism diopter.
yes, in A pattern, the difference between up gaze and down gaze should be more than 10 prism diopter to say this is a significant A pattern. Okay, thank you so much, Dr. Asma.
Thank you.
Okay, who would like to take the next question?
I will take, sir.
Dr. Najla, okay.
Yes, sir.
Describe, please.
I can see a black and white photo of a anterior segment in which cover testing being done. When the left eye is being covered, I can see the eyes are moving upward, and when the right eye is being covered, the eyes are moving upward.
Okay, great.
So it's mostly a DVD.
Yes, DVD, dissociated vertical deviation. Great. So what are the three components of dissociated vertical deviation?
Upward movement, and there is cyclotorsion, and there is no corrective movement after removing the cover.
So the dissociated vertical deviation has three components, as you mentioned, hyper deviation, excyclotorsion, and exodeviation. Okay,
sir.
so three components together. And how to differentiate a patient with hypertropia or patient with DVD?
Yeah, in hypertropia, we can see the corrective movement of the other eye when we are being covered. Cover being when we do uncover test, the deviation will correct. But in the DVD, this is against it's a phenomena seen mostly in the essential esotropia. In this, the Sherrington law is not obeyed, so this corrective movement is not seen.
Which one not obeyed? Sherrington law,
DVD
Herring law.
Hearing's law.
Hering's law, yes, correct. So in a patient with hypertropia, when you are doing alternate cover test, the other eye will come from down to up. And the hyperdeviated eye, it will come from up to down. Okay? But
Yes,
in
sir.
DVD, if the patient is having, like this patient, a bilateral DVD, both eyes will come from up to down. Okay?
Yes.
Yes. And if the patient is having unilateral DVD, which is very rare, one eye only will come from up to down. The other eye, there will be no movement. Okay?
Okay, sir. Okay, sir.
The second difference between hyperdeviated eye or a patient with hypertropia and patient with DVD, that in hypertropia, the movement of the eye will be fast, but in a patient with DVD, usually the movement is slow.
Slow. Okay.
Okay? And
Okay, sir.
DVD will happen with which type of patients?
In essentially esotropia, but the onset is late onset.
Yes. So yes, exactly. Infantile esotropia is one of the conditions that will have dissociated vertical deviation. Also, infantile exotropia. Also, any cause that will anything that will cause vision loss in a child in early childhood. So basically, dissociated vertical deviation will happen if the patient lost fusion in a very early age. Okay.
Okay, sir.
So patient
Okay,
with
sir.
infantile esotropia, infantile exotropia, patient with congenital cataract, all those patients will have DVD, or many of them will have DVD. How would you treat DVD?
Yeah, we can try inferior oblique anteriorization.
Yes, inferior oblique anteriorization, or the other name, inferior oblique anterior transposition.
Yes,
So where you will put the inferior oblique?
that I'm not sure, sir.
You will put it at the same level of the inferior rectus insertion. So that is the
Okay,
anterior transposition. And sometimes you will put it even anterior to the inferior rectus insertion. Okay, sometimes.
okay, sir. Mm.
Okay, so that is one procedure that we can do for dissociated vertical deviation DVD if the patient is having DVD and inferior oblique overaction. But if the patient is having DVD with no inferior oblique overaction, what can we do?
Uh, then superior rectus and superior rectus we can weakening procedure can do in
Yes, we
DVD.
can do either superior rectus recession or superior rectus Faden, posterior fixation
Okay.
suture for the superior rectus. Great.
Yes, sir.
Okay. So yeah, DVD. DVD also we have two types clinically. One called latent DVD that will appear only after covering the eye. The other type of DVD is the manifest DVD that will appear even if we are not covering the eye. Okay. What is the name of
Okay, sir.
this occluder, Dr. Najla?
Spontaneous DVD. Spontaneous DVD.
Manifest. Yes.
Yeah.
Yes. What is the name of this occluder?
Occluder. I'm not sure, sir.
Okay, this occluder where you can see the eye behind, you can see the eye behind, that is called Spillman occluder. Spillman occluder. It is very useful in patient with DVD, so you can see the upward deviation of the eye behind the occluder. Okay?
Okay, sir.
Okay, great. Thank you so much, Dr. Najla. Who will take the
Thank you,
next
sir.
question? Any volunteer?
I will take, sir.
Okay, Dr. Rufaida.
Yeah.
Okay. Describe Dr. Rufaida, please.
This is a photo of 9 years of young girl in primary position. There is a slight hypertropia in the right eye. Also in the up gaze and the left is slight hypertropic. And when we do in the dextroversion, the left eye is still hypertropic, and all leave version no. In the up gaze, the right eye is the left eye is hypertropic, and then also when we do up dextro, also there is left hypertropia, and also here in the levo also normal. And when we do in the down gaze, still the left eye hypotropic. Yeah. Yeah, this is Brown syndrome. It is in with the abduction, the left eye is hypotropic. Yeah.
So when you say Brown syndrome, you need to mention which eye. Brown syndrome is not.
Yeah, left eye.
Yes, you need to mention this.
Yeah,
okay?
left eye, sorry.
So the left eye Brown syndrome, yeah. But regarding your description, I will just make it again. There is very mild left hypotropia in primary position. Patient is having shoot in dextroversion in the left eye, and here
Yeah,
patient is having a limitation of adduction in the left eye, and
yeah,
here there is also limitation of adduction, but it is limitation of elevation, but it is lesser than the adduction. And in the abduction, left eye is almost normal elevation and abduction. Okay, so
yeah.
usually in Brown syndrome, the patient will have limitation of elevation on
Elevation,
abduction.
on
On
abduction.
abduction. In elevation, there is limitation, but it is lesser than that on adduction. And in
Mm.
abduction, it is almost normal elevation. Okay?
Yeah.
Okay. So regarding Brown syndrome, what are how do you classify Brown syndrome?
Congenital and acquired.
Great.
Yeah,
What
congenital
are the
Brown
causes?
syndrome.
Yes. What are the causes of acquired Brown syndrome?
Causes may be iatrogenic and maybe also to systemic disease, rheumatoid arthritis, sinusitis, and scleritis also. Iatrogenic from buccal or from yeah,
Yes.
buccal. I remember the
Buccal
buccal. Yeah. Mm.
and one more strabismus surgery that can cause iatrogenic Brown syndrome.
Yeah, I try to remember. I'm not recall. Yeah.
If
Buccal
we do
and
superior oblique tucking sometime,
yeah, yeah,
that, like if we do large superior oblique tucking, that can cause iatrogenic
yeah,
Brown.
yeah, yeah.
Yes. Also trauma, canine
Trauma
tooth
can, yeah,
syndrome
yeah.
can cause
Mm.
Brown syndrome.
Brown
Okay.
syndrome, yeah. Mm.
Yes. Regarding the congenital, usually it present at birth, and like there is no specific cause for congenital. It is kind of essential type. Okay. So regarding the management, when you will manage or how you will manage Brown syndrome?
First, I will do visual acuity. I will treat any refractive error. Then I will treat any amblyopia.
Great.
If it in primary position there is abnormal head posture, or
Okay.
there is because there is differential here for this
We,
Brown.
we will come to differential, but just
Yeah,
complete
yeah, yeah.
the management.
Abnormal head posture, or there is hypotropy in the primary gaze. Then I will go for superior oblique tenotomy, or with also expander of the tendon with silicone. All I will work on inferior oblique if I can. Inferior oblique.
No.
But most time we do on the superior oblique, yeah.
We
Tenotomy
do
or
we work only on superior oblique because it is a restrictive type of strabismus. So
yeah,
you
yeah.
need to restriction. We don't work on inferior oblique muscle in a patient with Brown syndrome. You need to treat the pathology. You need to treat
Yeah. If acquired, we have two choice. We can give steroids systemic or around the trochlea.
Yes, we can inject triamcinolone or betamethasone in the trochlear area. That is
Yeah.
local treatment, or we can give systemic steroids, especially in a patient with autoimmune diseases like rheumatoid arthritis, scleritis. Okay, great.
Yeah.
Okay, so regarding the indication, as you mentioned, if the patient is having anomalous head position or hypotropia in primary position or significant downshoot, okay, all these are indications surgery. Okay, what type of anomalous head position will present in a patient with Brown syndrome?
Chin up. Chin up
Okay.
and head tilt to the same side, and I think face turn to the other side, but I'm not sure.
Yes. Usually the most common is the chin elevation, as you mentioned, and the head tilt. Okay, so regarding the surgery, we can do superior oblique tenectomy, but now we are not doing it so much because if you did superior oblique tenectomy, what will happen?
I think vertical, another vertical deviation.
Yes, superior oblique palsy will happen. So the
Yeah.
patient will have hypertropia rather than hypotropia.
Hypotropia. Yeah.
So we prefer more the guarded procedures like silicone expander or something called loop tenotomy or chicken sutures. Okay.
Yeah.
So these procedures, you will do weakening for the superior oblique, but you will not, remove the action of the superior oblique completely. So you will not have superior oblique palsy post-operatively. Okay,
Yeah.
great. Thank you so much, Dr. Rufaida.
Sorry, can I ask you, Saya?
Yes.
In these 9 gaze, or when we do vertical component or these oblique muscles, really we confuse. Now, when I start to describe, give us a hint that we can elicit the deviation easily.
Okay. So
First, I look to primary position.
yes, exactly. Then you go for the side gazes first. Okay.
Yeah.
Then you, from the right, the dextro version, you go dextro elevation and dextro depression. Then you go
Oh.
levo version, levo elevation, levo depression. Then you comment on elevation and depression. Because those cardinal positions, usually they will isolate which muscle is affected. Okay. So,
Yeah.
for example, medial rectus, lateral rectus, superior rectus, inferior oblique here, inferior rectus, superior oblique here, superior oblique, inferior rectus, lateral rectus, medial rectus, superior rectus, and inferior oblique. But here, both superior rectus and inferior oblique, and here, both inferior rectus and superior oblique. So usually we focus on those gazes, okay?
Yeah,
So from
isolating.
primary position, and then you will take it and you will see a pattern. Like in this patient, here hypertrophy is not very prominent, but here you can see limitation of
On abduction.
on abduction. It is better in elevation and it is almost normal in abduction. So this is a patient with left Brown syndrome. So you just need, don't panic and see a lot of 9 gaze pictures. So you will be more familiar. You need to see many photos as much as you can and test yourself. Like in those pictures, do not read the comment under the picture. Just test yourself first, then read the comments and see if you are figuring out all the abnormalities in the extraocular motility or not.
Yeah,
Okay.
thank you so much, Dr. Amr.
Dr. Amr,
Yeah.
I have a question. In the book, they've classified Brown syndrome into mild, moderate, and severe.
Yes. Yes.
How does that classification? I mean, I don't understand what's the basis of that. How is it mild, moderate, and severe?
Usually, a patient with mild Brown syndrome, there will be no hypotropia in primary position. Okay.
Right. Right.
For moderate Brown syndrome, you might find a very small hypotropy in primary position, but you will find limitation of elevation or adduction like this -4 at least. Okay. In a patient
Yes.
with severe Brown syndrome, usually you will have significant hypotropia in primary position. Okay, so usually for mild cases, we do not do any surgery. For moderate
Right.
cases, if the patient is having significant anomalous head posture, if the patient is having significant downshoot, we will go for surgery for a cosmetic reasons. But in severe Brown syndrome, usually patient will have significant hypotropia.
Okay.
Okay,
And thank you. And one more question. Why do they have downshoot in adduction?
because the superior oblique is very tight. And
Right.
that is the action of superior oblique. It will cause depression on adduction,
Okay.
right? The
Superior oblique is
superior
tight.
oblique is depressor. It is a depressor,
Yes.
not elevator. And
Right.
because it's very tight, the eye is not going up at all because it is pulling the eye downward. Yes. Am I right?
Yeah.
What is the action
Yeah.
of superior oblique? In torsion or
Elevation and
abduction?
adduction.
It
Depression.
is
Depression and
torter and
depression.
depressor. It is
Sorry,
not
depression.
elevator.
Sorry, depression and adduction. Yes.
Depression and
Yes.
retraction.
So it is
In this, it will
pressing
cause
the
the
eye because it
ipsilateral
is.
head tilt. It will cause ipsilateral head tilt.
It will cause head tilt.
It's head tilt ipsilateral. I mean, in the superior or the Brown syndrome, like in the superior oblique palsy, we get a head tilt towards the opposite side. So in this, we get the head tilt towards the same side. Like if it is in the left side round, it will be the head tilt will be towards the left side of the patient. Like what would be the position of the head in this?
I will answer. Just give me 1 second. I just want to go through one more question
Yeah.
before forgetting about the differential diagnosis of Brown syndrome.
Yeah.
Yeah.
Dr.
Inferior
Rufaida,
oblique.
can you just finish this
Inferior
question?
oblique palsy and superior oblique overaction, and also you
Inferior
have
oblique
mono
palsy,
elevator palsy. What?
Wait. Inferior oblique palsy. Okay. What else?
Mono elevator palsy.
Monocular elevation deficit. Yes.
Yeah. And also the other overaction of the superior oblique. It enter and move.
Okay. Superior oblique overaction. Okay. What else?
This restrictive also. I
One
recall
more
this.
differential diagnosis, very important.
You have inferior oblique palsy, you have mono elevator deficit, and this
Inferior rectus restriction, which can happen in the blowout fracture.
blowout fracture. Yeah, I remember
Yes.
now.
Yeah, so
Yes.
there will be
Blowout
inferior
fracture.
rectus trapment.
Yes.
That can
Regarding
result.
inferior oblique palsy, how to diagnose it?
By ocular motility, you will find that the restriction of elevation in abduction. Here in abduction.
In inferior
Yeah.
oblique palsy, you will do something called 3-step test.
Yeah, 3 steps. Yeah. You will find, yeah.
Yes, and also you will find what in the
In Brown
fundus and
excyclo torsion.
palsy, you will find
Yeah.
intorsion, fundus intorsion. Yes.
Intorsion. Yeah, هي كده.
Yes. What else?
In
Brown syndrome.
in mono elevator palsy, you will find that the depression in
The elevation.
elevation in horizontal plane in abduction and abduction.
Yes, there will be limitation of elevation on adduction and abduction. in the same
Aye.
manner. Yes.
Yeah.
Okay. And in trauma, what you will find?
Find hypertropia in the primary case.
Hypotropia.
Hypotropia in the primary case.
And
restriction. What do we call it?
limitation of elevation as well.
Limitation of elevation.
And
the other sign of trauma.
Like, yes.
By force section test, I think. By force section test, I can differentiate.
Anesthesia in the infraorbital area over the skin.
Yeah, crepitus and if we do step deformity, also we find sometimes. And by force reduction test, I can differentiate between them. No, I think in force reduction test, a positive in the two.
Yes, it is also positive in Brown syndrome, but usually
in Brown syndrome and in
history of trauma will help you. That is
yeah.
one thing. So if you did CT scan orbit for the patient, you might find inferior rectus entrapment in
Entrapment, yeah.
such cases.
Yeah.
Okay. So, yeah. Okay. We will go for the next question. Who would like to take it? Any volunteer for the last, I think, the last question? Hello?
Okay, okay, sir, I will take it.
Dr. Arshi, okay. Comment, please.
Okay. This is a case. This is a picture showing three gazes of a female, in which I see in the primary gaze, the right eye is a little bit no, the right eye is a little bit ptotic and a little bit outward in the primary gaze. Then when the girl starts to look towards the right side, there is restriction of the abduction in the right eye and a little bit restriction of the adduction also. And the right on the right gaze, there is a um, downward movement of the right eye. While when the girl is looking towards the left side, the eye is getting elevated. The right eye is getting elevated. So it looks like right side inferior of no, I don't know what it is. Like right side is going.
Duane battery.
Abduction is restricted in the right eye, but
Yes,
in the
here-
left side, oh, there is a downshoot. There is upshoot of the right eye. So can be Duane's, yes. Narrowing of palpebral aperture of the right eye.
yes. In primary
Type
position,
1.
in primary position, what we are having in primary position?
In the primary position, the right eye is looking a little bit divergent and I
Patient
mean
is
in the
having
exotropia, and a
right.
little bit the lid is also ptotic.
Okay,
If
but
I
mainly
compare
the
the
right
palpebral
exotropia,
aperture.
right exotropia in primary
Right
position
exotropia.
with
Yes.
limitation of abduction in
Abduction,
the
yeah, in
right
the
eye
right eye, yes.
and
Uh, when I'm doing adduction, the eye is going up. So there's upshoot on adduction
also
of the right eye.
narrowing of the palpebral fissure. So
And there's narrowing of palpebral fissure, yes.
compare this palpebral fissure height with this one. There is significant narrowing of the palpebral fissure, and also
Yeah.
there is retraction, but we cannot comment on this on a photo. It is more obvious when you are examining a patient. So the
Yeah.
patient is having right exotropia with upshoot and narrowing of palpebral fissure and globe retraction on adduction with the limitation of abduction in the right. So
In the
also
right.
here we have also limitation of adduction as well. Eye is not going in. So
Yeah, it's going up. Yeah. So maybe it is type 3, in which both abduction and adduction is restricted.
yes. So mostly this is a Duane retraction syndrome type 3. So what are the types of Duane retraction syndrome?
So there are 3 types of Duane syndrome. Type 1, in which abduction is restricted, and there is narrowing of palpebral aperture on attempted adduction. Then in type 2, the adduction is restricted, and in type 3, both abduction and adduction is restricted. But
Yes.
narrowing of palpebral fissure will be there in all the cases.
Yes, yes. So to differentiate between the 3 types, in type 1 DRS, you have 1D, only limitation of abduction. In type 2 DRS, you have 2D, you have only limitation of adduction. In type
Yeah.
3 DRS, you have 3D. You have limitation of both abduction and adduction. Okay?
Yeah. Yeah.
In type 1, usually you will have esotropia. In type 2,
Yeah.
usually it is exotropia. In type 3, patient might have orthotropia, might have esotropia in some cases, and might have exotropia in such case. In addition to
Okay.
that, all the patient usually will have globe retraction on adduction, and sometimes patient will have upshoot or downshoot on adduction. Okay?
Yeah. Yeah.
So
Yeah.
how would you approach a patient with Duane retraction syndrome?
The Duane's retraction syndrome normally, if it is not causing diplopia and much of the cosmetic difference, then we don't do anything until unless the patient has cosmetic deformity a lot. Because there is a co-contraction of medial and lateral rectus, and the lateral rectus nucleus is not well formed, so it is a congenital abnormality. So in this case, what we can do if it is much, then we can do in this case we can do weakening of the lateral rectus already weakened, medial rectus also
But
weakened, so we can
you
do.
always, okay, we will come to this case, but just let's go back to the Duane retraction syndrome in general. So in general,
Yeah.
in a DRS patient,
Yeah.
and in any patient with strabismus, we will take the things in a systematic way. So we need
Yeah.
to examine the visual acuity, anterior segment, posterior segment, psychoplegic refraction, treat
Yeah.
amblyopia if any, and give refractive correction if the patient is having a significant refractive error. And many patients with Duane retraction syndrome will have refractive errors, especially hypermetropia. Okay, so that is
Okay.
first thing. Second thing, indications of surgery in Duane retraction syndrome. What are the
Yeah.
indications?
Diplopia or any cosmetic like head tilt or face turn is there.
So if the
Then
patient
we
is
do.
having any anomalous head position, that is one.
Yeah.
Significant
Yeah.
anomalous head posture, okay, that is one.
Yeah.
Second,
Head posture and um diplopia,
okay.
if there's any diplopia, or if there's too much narrowing of the palpebral fissure.
Okay, if there is significant globe retraction, if there is significant upshoot or downshoot, and if there is horizontal deviation in primary position, if the patient is
Yeah.
having esotropia, exotropia in primary position, that is also an indication for surgery. So, in summary, anomalous head posture, horizontal
Yeah.
deviation in primary position,
Yeah.
severe
Yeah.
globe retraction, severe
Yeah.
upshoot or downshoot. So those are the four indications for surgery. Okay.
Okay. Okay.
So in such patient with exotropic Duane and
Yeah.
upshoot, what type of
Yes.
surgery can be done to treat both?
If it is exotropic, we never do resection here, so we will do recession. So if it is exotropic, we will do medial rectus recession.
No, exotropia, Dr. Arshi.
Exotropia.
No.
Yes,
So
exotropia.
you
So
need to
in
make
that
it
we will do
possible.
lateral rectus recession.
Yes. So we will do
Lateral
lateral
rectus
rectus
recession.
recession. And
Yes.
because of the upshoot in this patient, what can be done for the upshoot?
For
There is
the
a
upshoot,
procedure
we can, because
called
there's upshoot, superior
Y
oblique, inferior
splitting
oblique,
of the lateral
overaction.
rectus. There is a difference
What?
between upshoot and inferior oblique overaction. They are not the same
Yeah.
problem. Okay. So in
Yeah.
patient with
Yeah.
retraction syndrome, upshoot is not due to inferior oblique overaction. It is due to the tightness of the lateral rectus. Okay. So in
Yeah.
such patient, we can do lateral rectus recession with Y splitting of the lateral rectus. Y splitting will treat the upshoot and recession will treat the exotropia. So we can do only one muscle and we can treat
Yeah.
both the problems with one muscle. Lateral rectus recession with Y splitting. Y splitting, okay?
Y splitting is like alphabet Y.
Yes, you will split the lateral rectus into two halves and you
Yeah.
will the distance between the two halves will be more than around 15 millimeters between the two halves of the lateral rectus. You will put the superior half and the inferior half away from each other. So that is called Y splitting of the lateral rectus. Okay, great.
Yes,
Thank
vice
you,
splitting
Doctor.
of the rectus. Okay.
Okay.
Fine. Yeah, thank
So
you.
last question, who will take?
Yeah.
Any volunteer?
I will take it, sir, Dr. Temina.
Dr. Timina, please comment on this picture.
Okay. In the this is in the primary position, there is a slight esotropia of the right eye. In dextro version, there appears to be slight underaction. There appears to be slight limitation of the left adduction, left eye, and in um, levo version, um, there is inability of the left eye to abduct.
Okay.
So this is left a limitation of left abduction.
Okay. Yes, limitation. Left eye, limitation of abduction and left inward deviation and comment fissure height here.
narrowing of the palpebral fissure on adduction.
Yes. So what it could be?
So this is type 1 Duane's.
Great. Type 1 Duane retraction syndrome, esotropic Duane. So
Right.
such patient, what can be done surgically?
Surgically, we can do medial rectus recession. Weaken the
Okay.
medial rectus.
Okay. So I will give you a scenario. If a patient with Duane retraction syndrome type 1 is having like 15 prism diopter of esotropia, what will you
Right.
do?
15 prism diopters of esotropia.
Yes.
So correct 3. So I will do approximately 5 millimeters of recession.
Great. So you will do unilateral medial rectus recession in the left eye, in the affected eye, and you will do
Yes.
around 5 millimeter. Yeah, I agree. Okay, great.
Yes.
If the patient is having, say, 30 prism diopter of esotropia, then what will you do?
30 prism diopters of esotropia.
Yeah, and he's having unilateral Duane retraction syndrome, say, in the left eye.
Right. 30 prism diopters. So then I will maximum recession I can do is 8 millimeters of the medial rectus, but I need around 10.
In Duane, we don't do anything beyond 5 millimeter. 5
Right.
millimeter, 5 millimeter is the maximum amount of medial rectus recession in Duane retraction syndrome. Otherwise,
Right.
you will get consecutive exotropia and limitation of adduction. So
Okay.
we will 5 in the affected eye. That is the maximum. How will you treat the remaining angle?
So I can do transposition of the superior and inferior rectus muscles to the lateral rectus.
One muscle is enough usually. We can do superior rectus transposition to the superior rectus transposition laterally, superior to the
Right.
lateral rectus insertion. That is one option. The second
Right.
option is do medial rectus recession in the normal eye. That also can help. Okay.
Right.
So in Duane syndrome, you can do medial rectus recession in the normal eye if you have a large angle, esotropy.
Right.
Okay. That
Okay.
also can.
Right.
Yeah.
Okay.
So much.
Thank you, sir. Thank you.
Okay. I think I am done with my slides. Um, is there, can you hear me?
Yes, yes, we can
Yes,
hear you,
sir.
Dr. Amr.
Is there any doubts or anything that you want me to discuss before leaving?
Dr. Amr, the other thing that we want to know is when either you'll be taking another class for Bilshowski's test. That one we want more in that, and we want to know about whether there'll be any head tilt and in which direction it will be in the case of Brown syndrome.
Okay, so in Brown syndrome, mainly there will be chin up or chin elevation, and there will be face turn away from the affected eye. Okay, face turn
Yeah.
away. For example, if the patient is having left Brown syndrome, like the case I mentioned, the patient will have right face turn. Okay,
Okay.
mainly. Sometime you
Mm.
might have head tilt, as I remember, to the same side, but I'm not sure. I will check this again, and I will let you know in the group. Okay.
Yeah. Okay.
But I rechecked
Okay.
again. It is more of chin elevation and face turn away from the affected eye.
Okay. Okay.
Regarding the
Okay.
three-step test, yes, we can make a class.
Yeah. Please.
Anything else?
Sir, could you just once more describe about the DVD, dissociated vertical deviation management?
Yes. So in DVD, if you have DVD with inferior oblique overaction, then you can do inferior oblique anterior transposition. If you have DVD without inferior oblique overaction, then you cannot do inferior oblique anterior transposition. You will work on superior rectus. So you can do whether superior rectus recession or superior rectus Faden procedure, that we call also superior rectus posterior fixation sutures.
Okay, sir. Okay, okay.
So, is there any role of anteriorization of inferior oblique in cases of inferior oblique overaction?
In a patient with severe inferior
Crime.
oblique overaction like +4, sometimes we do inferior oblique anterior transposition. We put it at the same line or on the same level of the inferior rectus insertion.
Okay.
Okay,
So, which
but
is
usually
more stronger? Which is more stronger, like
inferior oblique
inferior oblique
anteriorization is
anteriorization
more
or
stronger
recession?
than inferior oblique weakening.
Inferior oblique weakening is more stronger. Okay.
No, anteriorization is more is the most powerful procedure. Anteriorization,
Okay.
anterior transposition, that is the most powerful.
Okay. Okay.
Okay. Actually, in
Yeah.
anterior transposition, we are shifting or we are changing the action of the inferior oblique from elevator to a depressor. Okay.
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 Normally, inferior oblique is an elevator, but when you are doing anterior transposition, you are
Yeah.
shifting the inferior oblique, you are making it a depressor. Okay.
Okay. Yeah.
But in
Okay.
but in inferior oblique recession or inferior oblique myectomy, you just want to stop the inferior oblique from elevating the eye.
Okay.
So inferior oblique anterior transposition is more powerful procedure.
Fine. Okay.
Nice. Right.
Thank you. Thank you.
Thank you so much for your time.
Thank
I
you,
have
Dr. Amr. Thank you so
sir,
much.
I have a
you.
question if
Yeah,
you
yeah,
can answer it
yeah,
regarding Duane, sir, Duane's retraction syndrome.
yes,
If
yes.
there is
Yeah.
a surgical indication,
Mhm.
so if is there any age limitation for the surgery?
See, usually for Duane retraction syndrome, we don't operate earlier like other types of esotropia.
Yes,
Usually, we operate around the age of 6 years, 7 years.
6 years. Okay.
If there is any indication, as I mentioned before.
Yes, if
I
there
know-
is self-clinication, I just want to ask about the timing of this surgery. Okay.
Yeah, yeah.
Okay,
yeah.
thank you
If-
very much.
Yeah, if there is indication, usually we operate around the age of 5 years, 6 years, unless you are having a very large horizontal deviation, you can operate earlier. For example, I have two patients. One of them is 2-year-old, the other one is 3-year-old. Both of them have a very large esotropia in primary position around 40 and 50 prism diopter. So I operate on them earlier. Okay. But
Okay.
if the patient is having small angle, only the problem with anomalous head position or something, then you can wait. So you will be able to have, more consistent measurements before taking the patient to operation theater.
Okay. With large deviation, you mean that more than 30 prism diopters, yes, sir?
Yes.
More than 30.
Yes.
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 Okay.
Yes. Usually, when we say small deviation, that is 15 prism diopter or less. When
Or
we
less.
say moderate deviation, that is 20 to up to 35. Anything
Okay.
beyond 35 or 40 prism diopter, that we called large deviation.
Okay. Okay, sir. Thank you very much.
Thank you. Okay.
One more question. In the essential infantile esotropia, the medial, when we do medial rectus recession, what is the
Yes.
correct age to do it? It should be done with less than 1 year, because if we do in less than 1 year, what about if the child develops inferior oblique overaction, which can be around 18 months of the age, and then superior rectus, which happens around 2 years of age. So do we need
Yes.
to do 3 surgeries, or what, how it will be managed?
So in infantile esotropia, we have 3 schools. Okay, one school will advocate to do very early surgery before the age of 1 year. Okay,
Okay.
so
Yeah.
they advocate doing very early surgery to give the patient a chance to have a binocular vision. Okay. The second school is to do early surgery. We usually do it at the age of 1 year or between the age of 1 and 2 years. Okay. So this school, they advocate that the patient might not have a fine stereopsis, but the patient will have gross stereopsis. The third school, usually they will do the surgery after the age of 2 years, and they advocate doing the surgery after the age of 2 years, as you mentioned, after inferior oblique overaction and DVD will happen. So they will do all the surgery in one session. They will do inferior oblique weakening, or they will do anterior transposition if the patient is having DVD with inferior oblique overaction, along with medial rectus recession. Okay, so we have 3 schools. Most of the people, there is no consensus. It is still a controversial issue, but most of the strabismologists will agree on doing the surgery at the age of 1 year. Okay. And even if the patient develop afterwards inferior oblique overaction or dissociated vertical deviation, then you can do a second procedure for that. Okay. And we do the surgery that earlier at the age of 1 year, so the patient will have even a gross stereopsis afterwards.
Okay.
So that is
So
the
correcting the
justification.
correcting the inferior oblique overaction can correct some part of the DVD also, because if it is bilateral inferior oblique overaction, and
Yes,
we
if the
correct that
patient is
one,
having
correct a
both
part
inferior
of
oblique overaction and DVD, you will do only inferior oblique anterior transposition to treat both.
Okay, yeah, fine.
So if you have inferior oblique overaction and dissociated vertical deviation, you will treat both conditions only with doing inferior oblique anterior transposition.
Yeah, so both can be corrected. Fine.
Yes.
Yeah. Okay. Okay, doctor. Thank you very much.
Thank you so much.
Thank you so much, Dr. Amr.
Thank you. See you.
Thank you so very much.
Thank you, Dr. Amr. Thank you.
Goodbye. Thank you. Bye.
Thank you. Good day. Thank you.
Thank you, Dr. Amr. Thank you so much. Thank you.